Yeah, good morning everyone. After that wonderful sort of a broad talk touching multiple problem statements, giving an idea of how AI can really be used. I'm happy to sort of come back on stage on my favorite academic institution where I did both my master's and PhD, and where almost my journey of a startup started. Yeah, I'm Geetha, founder CEO of Niramai. Basically, I was a principal scientist at Hewlett-Packard Labs after I finished my PhD, and then I was head of AI after 17 years at Hewlett-Packard at Xerox. And of course, I was working on multiple research problems, including COVID, and like one of them, what is the impact done actually along with Chiranjeev Bhattacharya ji at CSA. We actually did develop a AI-based COVID screening model used by 10,000 doctors, in the rural areas to say whether they need to really send to a PCR or not. So some of these are possible to be deployed, especially in low resource settings. And what I'm going to do today is to sort of focus on one problem and my journey as a scientist to quit my job and become an entrepreneur, because I really wanted to see how an AI model can go on the ground and make it. And that learning is what I thought I will share, which adds a different color to what ma'am presented before. And thank you so much, Professor Sinha and Professor Dixit, for inviting me. So I think it's very obvious. We talked about how AI is changing the world, and particularly if you look at AI impact in healthcare, pretty much healthcare is the last impacted in AI. Of course, we use Uber, Ola, all of them, many other wonderful applications we have just gotten so used to. But healthcare is the least or last one which is getting, and this symposium is right on time. And we talked about multiple use cases, and you have many speakers going to talk about individual aspects of it. The place where AI has started making an impact, even around the world, is in the analysis of medical images. As the first phase of making a clinical decision support, or supporting or assisting in clinical decision support. Of course, using AI in a non-clinical setting, like matching the patient with the right doctor and prioritizing the patients for review by the doctor. Those things are a little bit more similar to the other domains. Here, when it comes to clinical decision support systems, like previous speaker mentioned, the class imbalance becomes very, very important. What do we mean by class imbalance in this scenario is that number of people who are healthy is much, much more than number of people who are unhealthy, which is good for the company, good for the world, but it's very bad for a machine learning engineer or a researcher, unfortunately. And that is the huge imbalance problem we are trying to solve. And when I go to a small class where they're trying to say AI in healthcare, I'll say, see, let's say actually, like, we can have like one person in 100 member screen to have cancer, right? So if that is the case, I tell them, like, it's so easy to develop a 99% accurate algorithm. All you have to say is no, and you get 99% accuracy. So we actually devise different metrics to actually evaluate the healthcare and so on and so forth. There are several other problems, which the challenges rather, which make AI in healthcare, particularly clinical decision support, more challenging. So of course, when we talk about medical imaging, we are talking about these kind of images with usually radiologists are trained to interpret minute patterns which may be indicative of abnormality. The final ground truth is, of course, tissue-based analysis and so on, because you can't keep poking to take tissue everywhere else. Imaging becomes a very, very important step to diagnose any huge issue, as we all know. So again, in AI in medical imaging, from an AI scientist perspective, there's several problems. Previous speaker touched upon some of it. One is, of course, the classification, but it's not really classification. Many times it's about what type of abnormality can I pull out from here, so that the doctor makes a decision what exactly is the disease that it's showing. Like, for example, this is offshoot of COVID data set, NIH data set. It had about 14 different abnormal patterns that one could extract, and you could write a multitask learner and learn all together, and then say, okay, we see there is a nodule, there seems to be an effusion, is this, the doctor makes a decision. So those kind of problems are possible. When we actually take multiple images of the same organ, how do we align them? How do we register them? Especially when we are talking about not a visual image like this. If I'm taking a picture of this stage, for example, from different views, it's visually available that Geetha is standing here or podium is fixed, and you can actually do the registration across different views easily. But when you're looking at it from a human body perspective, which possibly changes every minute, every microsecond when the a person is breathing, etc., registration problem becomes really, really challenging and interesting from a science perspective. And localization that talked about, so exactly where is the problem likely to be. And to address one very important concern that the esteemed doctor mentioned, it's about explainability. Right? When we talk about explaining the answer, explaining the thinking of the AI model itself, one aspect I've seen based on my experience of doing the breast screening one, which I'll talk about, is localization. That is, just saying somebody has cancer, you can't do much about it, right? Where is it? So that a follow-up diagnostic workup can be done at that particular point. The doctor can do an ultrasound at this, right breast, upper inner quadrant, 12 o'clock position. Then you go and do an ultrasound. The doctor does an ultrasound and confirms that it's something actionable should be there. Just saying yes, no, pretty much many times becomes an issue. But this is something that makes it more believable and transparent to the understanding. And several other use cases are possible. And of course, why we do it is maybe obvious. We're trying to sort of improve the productivity, making it faster, reduce misdiagnosis. Sometimes it could be calling out to, just being sort of over-diagnosis part of it, like when it's in the gray area, calling too many people, requiring biopsy is an invasive procedure, so you may have to reduce the number of false positives as well as reducing number of false negatives. Definitely is very, very important. We don't want to miss any cancer. But what actually motivates many of us, and probably the reason why I quit, was how AI-based healthcare can actually bridge the healthcare divide that exists in this world today, between developed countries and developing countries, between villages and urban areas. Even within a city like this, we have definitely two economic strata of people. And the kind of healthcare they get is hugely, hugely determined on how big the pocket is, literally. And it's not just the equipment, definitely that access to equipment and also access to specialists, given that there is a very, very important skill and takes a long time to build that expertise, and we have few in India. So this is where I firmly believe that AI-based healthcare can really help make affordable and accessible, high-quality healthcare available to everybody. So instead of speaking in sort of high level, now I go fully deep into one problem and take from the problem statement and the solution and where we are today. Breast cancer, it is the top killer in women today. 2,000 lives go every day because of this disease. It is 2,000 lives every day. Most of them could be saved. 95% survival is possible. But we end up many countries like India who has 50% survival. That means every alternate lady detected with breast cancer is dying within 2 to 5 years. In 2024, WHO data says about 2 lakh women got detected with breast cancer. About 1 lakh women died in the same year due to breast cancer in India alone. So this is the problem that we are trying to solve. And why late detection? Early detection definitely enables better treatment efficacy, reduced or improved health status, we would say. She doesn't need to sort of come back again and again, there may not be recurrence, etc. And most importantly, it also reduces the treatment cost. Treating a stage 1 cancer versus stage 4 cancer, the amount of money could be like 10x, and still you may not be able to save it. And this I learned from my own personal story, where I lost 2 of my cousin sisters to breast cancer, which made me quit my job as head of AI to start this problem statement, saying, can I really make something happen on the ground rather than just publishing papers, which is very nice, very important, but I said somebody has to take that extra step. And if you look at how the breast cancer deaths, when you map it to the different continents, you will find that 71% of these cancer deaths due to breast cancer is happening in low and middle income country. Clearly is a money issue. Not only that, why are they detecting late? It is because they are not proactively doing any test. Of course, the most standard test available for breast cancer is called mammography. And if you ask this question, for any lady between 40 and 69, say, have you ever had a breast cancer screening test with mammography? In United UK, you get 71% of them saying yes, at least once in 3 years, and these kind of things. And in India, you get the pathetic 1.3%. Only 1.3% women would have ever had a mammogram. I don't want to have a show of hands here, because I think we can do that offline. But this is the statistics, even with Dr. Rajendra Badvesa, who is to be the director of TMH. It's a paper from him which says that. So the question now is, how can we enable every lady to do a screening test instead of 98.7% of women detecting their cancer by hand and then coming to the doctor when it's a 2 centimeter or 2.5 centimeter lump, which is staged as per TNM staging, they say. If it is about 2 centimeters, it falls into stage 2 and 2.5, and it depends on which other nodes have been affected. It can get to 3 and 4 very quickly, right? So lymph node metastasis we call, and so on and so forth. So we usually detect in stage 3, 4. So how can we do that? How can we reduce that? By enabling early detection screening tool. It's obvious, but the numbers are alarming. So we then double clicked on that, saying, why is this problem, right? What is so different? Of course, money is one problem. How is it? Like what in the money aspect is bad, right? One is the machine itself is 80 lakh to 1.5 crore rupees on mammography machine, which is good, which is the one which is only proven to improve the survival rate with longitudinal study to improve by 13%, right? Which is good around the world. Now, but the machine, if it's costing 1.5 crore, how many of our small diagnostic centers can get that machine? And to operate that machine, you need a skilled resource, and she will know only how to operate this machine, and women are not coming, so there is no money, and then it increases the cost, etc. And also, of course, radiologists are the ones who will interpret it. So this is the access and affordability is the machine cost, as well as how do we do the operation lesser skilled manner. Second is also the experience. Women who do the test once, they may not come back because they don't like the experience. And third one is the physics limitation. Mammography is basically X-ray of the breast, and when you do a mammogram, cancer would be high density, so you'll see it as white, and if the person has a dense tissue, the whole breast appears white. And so you cannot see a white on white breast. And it's not what I am saying, it's tons of papers talking about. US FDA changing their guidelines of mammography last year, saying every mammography report should have the density mentioned, and if the density is high, she cannot, she needs an additional test like a breast MRI or something, which is super expensive anyway. And you can't let women have MRI every year, even though there is no problem. So here is an example of dense tissue where even a big lesion is missed and in the X-ray of the breast, and here it is actually identified very well. Who has dense tissue? Almost all women under 45 have dense tissue, and about 50% of women above 45 have dense tissue, which means that there considerable segment of women who require an additional test despite doing regular mammogram. And this is not an India problem, it is a whole world problem. And this is a sort of a more recent analysis for us, we came to know, but it means that world really needs an additional test beyond what people have been going through so far. And we said, okay, can we do something? Initially I started off with this as a problem statement, but I said, okay, can we do something different? So if you do the same thing again and again, density-based differentiation will lead to the third problem. So we said, can we look at another imaging modality, which is more affordable, accessible? And I stumbled upon a couple of papers which were in 1980s trying to use infrared imaging for breast screening, right? And there were papers on it, not really very, very systematic, but at least 100, 200 people looked at it. And so they were taking a thermal imaging device or an infrared, many of you would have seen hyperspectral imager. So there they took the infrared imaging and then they were doing the analysis. And here basically it's one of the electromagnetic spectrum, one of the ranges in the electromagnetic spectrum, and it is light in a different format. And what happens here is, based on the reflection or emission from the body, you actually computing the environmental emissivity parameters, you can actually convert that into a temperature value, likely temperature. It's not an exact temperature, it's not a thermometry device, but it can give you relative temperatures very, very nicely. How is temperature related to cancer? So we looked at a lot of the medical science around it. Cancer cells, what is definition of cancer? Irregular multiplication of cell, which is basically higher metabolism, and that actually increases the temperature by very, very small amount, 0.02 degree, 0.04 degree. That is one aspect. And the cancer cells require a lot of food, there's more blood flow coming into that. So we said, can we model vascularity, blood flow to some areas, and can we model metabolism with these sort of high resolution thermal imaging? And of course people had tried to use it, and manual interpretation has challenges, especially if you see here, this is a heat map. This is not like a thermal kind of any physics heat map type of thing. You will see that 34 and 35 degrees Celsius both are looking red and light red. So it's really humanly impossible to figure out anything very, very precise in this particular fashion, unless she has a late stage cancer which is showing up, definitely shows up as white. So we said, okay, can we use AI here and make a difference? And that's sort of the piece where what we did is thermal analytics, right? So if you start using the images, it's not going to help. So we figured out a radiometric analysis piece where we hook up the computer to the thermal scanner device itself and extract the data much before it starts showing the images. We measure, or we extract 400,000, that is 4 lakh temperature points per person. And it's a high resolution temperature information with almost like 500 millikelvin, 200 millikelvin kind of thermal resolutions, using which we can actually model new biomarkers, new patterns which world has never seen before, right? And of course, a lot of seeping through the data, going through the deep learning, but deep learning ke liye data chahiye, data was not there. So a lot of effort over the last 9 years. So with this, what we generate is a complete explainable report which says whether there is an abnormality, likely abnormality or not, and what is the probability that abnormality is likely to be malignant, and also explaining the reason for this, right? So moving forward quickly about the tech part of it, so one of the main things that happens while we use infrared imaging is it makes the whole process extremely comfortable for the end user. Why? Because it's like a photography session. The lady sits there, click, 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 5 images are taken, and even the technician doesn't see the person not wearing clothes. It's just sort of going through, this is one of our hospitals. So she goes in, she sits in front of the device, and she just rotates to get the lateral and oblique views. 5 clicks are taken, and of course what we are showing is a thermal image, but the temperature maps. So I spent some time on this. What is the sort of the novelty in this whole thing, and what do I do with the 400,000 temperature points we come in? We realize just like we have the BRCA and other genetic morpho. Can we think about minute biomarkers from the thermal scans? There will be some patterns maybe, right? Because it's not that only the cancer cell will has high temperature, because there is a convolution and convection and all of that inside the tissue. It actually spreads in a very, very different pattern. So the pattern of spreading of the temperature itself, we try to sort of model as well. And then we had to sort of bring in some kind of contrast so that this action happens in sort of in a live way. So we blow cool air for 5 minutes. Just simple cool air is blown because people wear tight clothing. We don't want false positives. So with that, first thing is, in a density domain, we talk about lump, which is a hard stuff, right? In thermal domain, we said there is a notional equivalent thing, which is called a hot spot. It's a common name. That is something that is high temperature. But what is high temperature? Everybody is 37 degrees Celsius, and so how do we define, right? Is it a fixed point? So earlier doctors, 1980s, when they're trying to say, okay, anything that is max minus 32 degrees. So they were having very, very high level sort of notion of some temperature values. We said, can we learn that whether something is hot or not from the temperature distribution itself, right? So we modeled the temperature threshold learning itself as a machine learning problem. and then said for this particular person, this threshold is hot, or rather anything above this threshold is hot. Then we defined this concept of hotspot. And there's tons of information and science available, the radiologist perspective, where they can look at a lump and say whether there's an abnormal electron. One such thing is irregularity. So we said, okay, can we model irregularity? So we mapped it to an imaging technique called fractal dimension. So it was about sort of looking at what kind of features are looked in to mammography, ultrasound, MRI. I went through the courses of these to see how radiologists interpret, getting the semantic patterns, map it to the thermal domain. And then of course after some time when we started having data, we started doing a lot of deep learning networks and so on and so forth. Another important aspect is if the cancer is very, very close to the chest wall, then it may not even traverse to the skin because we are just looking at the skin temperature. Then we started sort of staring at this kind of false negatives, deep tumors, and we figured out we can actually try to extract some high thermal activities, or rather structured thermal activities, which ended up to be vascularity. It's not really high, but it's more like extracting structural. So this again is a deep learning unit that we use, where we can actually extract structured patterns, and it turns out that this is a cancer patient where right side there is more high thermal. This is an equivalent imaging called Doppler, which actually tries to do the same thing. So all those, and then when we gave it to the end user, they actually made a lot of mistakes, so we had to do a lot of AI saying, what is the angle of incidence? Is she actually doing the, the 5 views correctly or not, and so on and so forth. So this is, and then once you get the network identified with deep learning, then we start modeling the different parameters of it and do the asymmetry and so on and so forth. End result, about 25 different machine learning algorithms convert the 5 images into a report. Because I didn't have time to sort of go through, I just select many ML, many IM, all of those things. You see, there's all of these algorithms come together to make it happen. I know I'm running out. So in order to bring in the explainability that the doctor clearly mentioned, first thing we had to do was use the same nomenclature that mammography and ultrasound doctors are using. Of course, I have 2 wonderful doctors and mentors in our team, Dr. Rampika sir and Dr. Sudhakar sir, with whom we worked with very closely, and they said, okay, equivalent of a BI-RAD scoring, we actually give a score which any doctor can understand what this the AI model is saying, right, in terms of the end result that it is predicting. And then some explainable score, is it because of the more tissue activity, because of vascular activity, or because of some milk duct issue. So we give different scores. These are all probability scores, which helps them go to the next level saying yes, and nothing like not marking it, right? Once you mark it, you can actually check whether it is right or not. So this is what the sort of whole journey has been, multiple sort of challenges, etc. And definitely we had to do clinical testing. Right, and I think one of the audience said, right, if you show an image and ask 2 different doctors, they may actually give 2 different answers because it's very, very hard to interpret an image, right? Especially, some cases will be clear, but there are other cases. So what we said is, we will compare our test with mammogram, ultrasound, and until biopsy, right? So that's what we did, and we have now 58 papers. I'll just flash a few results in the interest of time, and happy to share with you. So we focused on sensitivity, that is, how can we give a test in a way that there are close to 0 false negatives. That is, when we say no, it's a no, highest negative predictive value and so on. So we compared with mammography, ultrasound. Then we also had to sort of look at if mammo is done, if you add this, will it add value or not? So different kind of settings had to be done. So we made this as, if Analytix is saying yes, then second radiologist will come and see the mammography so that we know we can go ahead and pick up even in dense tissue. And then we did some performance analysis in pure dense breast, young women as a meta-analysis. That was also extremely promising and published. All these are peer-reviewed journals that is published in. And just to give one example, this is the dense tissue where mammogram is not able to make out the difference between right and left, and then physiologically the thermal scan is able to determine something that was not, is not visible, and it's just a limitation on the physics part of it. We are now, of course, done several rural screenings as well. We have a Nature digital medicine paper which talks about how 15,000 women were screened and only 3% of them had to be actually brought back to the hospital to do a further detailed analysis, where of course we brought many more. Not everybody was going to have cancer, but we are sort of working on them. So this is one of our flagship projects. Where we actually determined 3 times more cancer detected with this. So I'll stop here. Would love to answer any questions you may have and thoughts on this.